Welcome once again into the Radiopedia Reading Room, a podcast unconcerned with books or poetry, tasseography or palmistry. It's a radiology podcast. My name is Andrew Dixon, and joining me, he looks a little guilty. Was it the professor in the reading room with the muddler, perhaps? It's my co-host, Frank Gaylard.
To try and murder someone with a muddler, that would have to be a very large drink that you were preparing. The largest mojito ever.
Yeah, it would be. Yeah, Professor Plum in the greenhouse with the muddler or slapping his mint. This episode today, Frank, is a forensic radiology themed episode for the main segment. So hence I thought I'd go with a bit of a Cluedo reference up top. So we're going to be listening back to a panel discussion from Radiopedia 2022 featuring Jeremy Jones, Chris O'Donnell and Claire Robinson. So looking forward to listening to that.
Excellent. I've only ever played Cluedo once or twice, I think. I love the idea of board games. My son and I, my eldest son, who loves the idea of board games, especially really complicated ones, we'll go to Mind Games, which is our local game shop, and we'll look through all the board games and pick one, and then come home and read the 30 or 40 page manual of how to play. It can be
massive, yeah.
And then we play it like once, and then it's like, it goes on the shelf. It's really more the fun of picking the board game than the actual playing it. It's also hard because my youngest son, he doesn't mind board games provided he wins.
All right.
That's not that much fun because the one fun part about playing board games with 10-year-olds is defeating them.
One of the things I don't like much about board games is actually the competitiveness, and I kind of like those ones where you work as a team against the board.
There's some good collaborative ones.
Yeah. There's one that we play, Lord of the Rings, and it's similar to what you described there because there's this book, like 40-page description of how to play the game, and we only play it over summer when we're down at my in-laws' place, and my brother-in-law will get out the book and read the rules, and he knows all the rules. None of us know how to play the game, but because it's collaborative, we just sit down and we're holding our cards, and he just tells us what to do. He's like, "Oh, Andrew, you play this, and then I'll play that." And it's actually quite fun because we're just like, he'll just tell us what to do.
We just hang out.
And we always win.
We've been playing Pandemic. Have you ever played Pandemic?
I have once or twice, again, as you said, once or twice.
That's a collaborative one. And we've been playing it on the easiest setting, cheating, and we still haven't won, which just goes to show if there's actually a pandemic, like there has been one recently, I think, from memory, we're screwed. Like, you can't beat it. That's the moral of the story.
We should have known. The game came out first. We should have known that it was inevitable. We weren't going to win. Just let it go. Let it go. Now, I did actually write down some random Cluedo trivia, if you're interested, Gaylard.
Yes,
I thought we needed a little bit of positive stuff to talk about up top. So I won't test you. I'll just read them out, and maybe you can just react like a YouTuber. Just be over the top excited.
The 10 most amazing things you've never heard about Cluedo.
Oh, sorry, I haven't got 10, but that's okay. The 5. Now, so the Cluedo board game was invented in the early 1940s by Anthony Pratt and his wife Elva, who came up with it while they were holed up at their home in Birmingham during World War II air raids. And they patented it, and then they sold it to UK games manufacturer Waddington's in 1948. So they named it Cluedo, which is a blend of the word clue and Ludo. Ludo was the name of a game in the 19th century that's Latin for I play. So there was kind of this already existing game. So they're kind of doing a play on words there. But then when Parker Brothers picked up the rights and took it into America in 1949, so just a year later, they shortened it down to Clue. So the Americans know it as Clue, whereas I think in Australia we pretty much call it Cluedo, right?
Yeah, absolutely. What is it with this renaming of things? Americans do it all the time.
They do it all the time.
Harry Potter, Sorcerer's Stone was it Philosopher's Stone?
Yeah. So they changed it to Sorcerer's Stone. Apparently Philosopher didn't sound right to them. It happens the other way as well. I remember that, Die Hard 4.0 in Australia. In America, that was actually called Live Free and Die Hard because apparently there's a state motto in Massachusetts, which is live free or die or something like that. So that was a kind of a known saying for them. And there's lots of examples, actually. I looked it up on Wikipedia earlier today.
Yeah.
There's lots of examples where, things have been changed just because, there might be overlap between how things are interpreted in different parts of the world.
There are some words that you can definitely understand why you would change it. I remember one of my ex-girlfriends, she went on exchange to America and she arrived at the family home where she was staying, and the father was there, and the daughter, who was going to be her classmate or whatever you call it, wasn't there yet, and he was showing her around the house, and they got to the mantelpiece, and the father said, "Oh yes, and there's Helen. She's the one with the enormous fanny." And I mean, for our listeners, the word fanny has a distinctly different meaning in America to Australia
Yeah.
and the UK. And it would be very inappropriate for a father to comment.
On someone's fanny. Yeah, fanny pack is definitely a word we don't use here. The other one that I remember, I think this was from like a Winter Olympic Games way back, and there was a brand big in Canada and maybe the US as well called Roots. And again, everyone's talking about, oh, how good's Roots? It means a different thing in Australia when you're rooting.
But surely philosopher and sorcerer are both words that are recognized.
I think so. I think that was the very first Harry Potter book, and
Right.
it was still very much unknown. I think if they had their time again and they knew it was going to be a success, they wouldn't have argued on the title. They would have
Yeah.
gone, whatever you like, JK. We're happy with
That's
that.
right.
But perhaps we should call this podcast different things in different parts of the world because in Australia we tend to call it, well, at least at my hospital, we call it the reporting room rather than the reading room. So maybe this should be the Radiopedia reporting room podcast in Australia, but the reading room podcast in the US.
We are at my hospital, we call it the bunker, where you do the reading. But I did bring the expression to do a readout back with me from Canada. I don't think there's a good alternative expression in Australian to the act of going through cases.
We do that as well. We call it, reading out. You're rostered to do a readout, so you go and sit with the overnight registrar and read out their cases with them. But generally, we still refer to it as a reporting room rather than a
so
reading room. But I wonder if there are different terms in different parts.
Well, let us know in the comments. Is that YouTube enough?
I've got more little random facts here.
Oh,
Do you
yes,
want some more? Okay, so the original murder implements, weapons, they were sketched by Elva herself, and apparently they were quite gruesome. So there was an axe and a cudgel, which is a stick, kind of like a muddler, I guess.
Yes.
A small bomb, a rope, a dagger, a revolver, a hypodermic needle. That's cool. Poison, and a fire poker. So they were the originals. And then, so they kept the rope and the gun and the dagger and then added 3 new weapons. Do you know what the 3 weapons were that they added? No, you're not a big enough fan of the game.
No.
The candlestick.
But aren't they all blunt instruments?
They kind of are.
'Cause,
Other
I
than
mean,
the dagger's not. And the
No,
revolver.
remind me of the game. You have to work out who the murderer was and what the weapon was, right?
Correct. Yeah, the 3 things. Yeah.
How could you confuse a rope with a small bomb? Surely even the most amateur of forensic pathologists would be
That's
able to
true.
distinguish between those.
That is true. So therefore, they probably did try and go towards more blunt force objects. This is related to the topic for today. So a candlestick, a wrench, and a lead pipe. The classic with the lead pipe.
That would be hard to distinguish, right?
The idea of the game is you don't get to examine the body, unfortunately.
That would be better.
Now, more random facts. Colonel Mustard was originally Colonel Yellow. I think Mustard's a better choice.
Much.
And then in 2008, Hasbro in the US, they revised the game and brought in a trophy and an axe. They brought back the axe and a baseball bat as new weapons. And they switched the Colonel from being a war hero to being a sports hero. So a few little changes. And then in 2016, the housekeeper, so Mrs. White, she was permanently killed off, tragic, and replaced with a new character, Dr. Orchid, a female scientist. And that actually, it reminds me, when I looked at a clip earlier from the Clue movie, which was in 1985, they did the opposite. They actually added in a new character, which was a sexy French maid.
Now, is Clue movie, was that known as Cluedo in Australia and the UK?
I think it was actually called Clue everywhere, that one. And I think when I saw it, I was kind of like, oh, that's interesting. They've deliberately changed the name because maybe they don't want to infringe copyright or something. But no, it was known as Clue in the US.
Well, that is possibly much more information about Cluedo than I ever wanted or needed to know.
You're the worst YouTube reactor I've ever had.
Is this where you're going to break the news to all our listeners that we're pivoting from being a radiology podcast to being a board game review and trivia?
Mate, it's light and shade. It's quite a heavy main segment in the podcast today, so I thought I'd lead off with something light, hence the Cluedo.
Oh, hey, speaking of reviews, before
Mm-hmm.
we move on, have you seen Oppenheimer?
Not yet, no. Seeing it in 2 days.
It's good. I took my 12-year-old son. We went to see it at the cinemas. It's long. It's like 3 hours of people in small rooms talking to each other. If you're going expecting a lot of special effects or a lot of explosions, there's
only
really
one
very
scene.
little.
Yeah.
Yeah, it's maybe 2 minutes, and the rest is just close-ups of people with wrinkles talking to each other. But it's great. Really liked
Well,
it.
maybe we can chat
Really
about
good.
it on a future episode. But let's get into this week's main segment. So this was a panel hosted by Jeremy Jones at Radiopedia 2022, so a year ago now. Jeremy had just given a lecture on how to be an expert radiology witness and how to give evidence. And he's chatting with Claire Robinson, who's a consultant radiographer at the University Hospitals of Leicester NHS Trust, where she has been involved in post-mortem imaging for more than 20 years. And Chris O'Donnell, who's a world-renowned necro-radiologist, that's a cool word, and consultant forensic radiologist at the Victorian Institute of Forensic Medicine here in Melbourne. So this recording does involve discussion of death, including homicide, as well as child abuse. So listener discretion is definitely advised. It is a fascinating discussion. So we'll listen into that now, and then Frank and I will be back for another chat.
I'm joined today by Doctors Claire Robinson from Leicester and Chris O'Donnell from Melbourne. Hi guys, it's great to have you with us. Now I've got a couple of questions just off the back of those talks. And the first one really is about how we got involved. So I wonder if I could come to you first, Claire. How did you get involved in this area of radiology?
It wasn't until I came to Leicester that I knew anything about forensic radiography. I'd never heard of it before. I was invited to go down to the mortuary and help do an X-ray. And I got talking to one of the pathologists down there, and he wanted to do some research, and that's how it started.
So your first foray into post-mortem radiology was really forensic radiology?
Yes. So yeah, as a radiographer, I was going down to the mortuary at the time taking the X-rays, and then we've progressed, and now we're doing PMCT more.
What about you, Chris? How did you get involved in post-mortem work?
I'm a clinical radiologist, and I was getting a bit bored with my clinical work, so I made an approach to our Institute of Forensic Medicine here in 2002. One of my colleagues' wife is actually a forensic pathologist, so at a Christmas party I just said, can I come along? And she said yes. So we start off with just plain films, and I've always had this sort of aim of trying to get clinical imaging or the techniques that we have in clinical imaging into forensic post-mortem imaging. And so it was a slow process. We had computed radiography, then we got digital radiography, and we managed to get a CT scanner in the mortuary, and we're up to our third CT now, and just in the process of tendering for MRI. So it's been a sort of slowly progressive process since I started in 2002. A CT scan went in 2005, and next year we'll have MRI. So it's been a sort of slowly progressive process of just getting it installed, and now pathologists are absolutely dependent on it. So now we've become a really important part of medico-legal death investigations. So they can't do without us. If we break down, the pathologists start screaming because they want the scans.
Yeah, and that came across in your talk, just the idea that actually the CT is really helpful for making the pathologists making decisions that they need to make. You say you've got 3 CT scanners?
No, third.
Oh, this
CT
is your
scanner
third.
We've replaced, yes. We started with a Toshiba. That went for about 6 or 7 years, and then we replaced that with a Siemens. We're just about to upgrade to a new one this year. Because you really put the CTs through their paces. I mean, you're doing head to toe. We probably do 25 to 30 cases a day, and they're head to toe scans, full bore. There's no dose modulation or anything. It's just full bore radiation dose. So it really slams the tubes. And the first scanner we had really was a big problem. We were burning tubes out left, right, and center. The Stratton tube in the Siemens is a lot better, and we haven't had as many problems. But it does take a toll on the scanners. So after sort of 6, 7 years, they're having more and more problems with maintenance and so forth. So that's why we have to keep upgrading. And plus, we want to get the new stuff. We do a lot of dual energy, spectral imaging. So we want to try and keep up to date as well with the latest technologies, as well as just making sure that we've got something that's robust.
So, Claire, as a radiographer, how did you feel about the first time you scanned a dead person and had the scanner up at full whack?
Yes, it was a little unnerving. It really is a balance because we still use clinical scanners. So all of our post-mortem work is done on a scanner that is still used for clinical radiology. So we have to have that balance that we do the best quality imaging that we can for the post-mortem work, as Chris has said, but we don't burn our tube out because obviously we don't want to ruin a clinical scanner. So it's a fine line, it's a balance, but we scan every 15 minutes for the deceased. And as long as you don't push it too hard, it doesn't seem to be taking too much of a toll on our scanner.
What sort of numbers are you doing then?
We scan about 8 or 10 patients a day. We only have the scanner for half a day each, Monday to Friday. And that meets the demand that's placed on us at the moment.
And as far as the forensic stuff, the victim identification, I think the thing that struck me was this idea of imaging the body and the bag, which was slightly disturbing to hear a little bit.
Yes, I think when you start getting involved in this work, you do have to start to think a little bit differently. But as well, remember that they are still a patient. It's still someone's loved one, but it does take a little bit of a mind shift. But yeah, particularly when you're looking at fragmented remains or people who have suffered very bad trauma, they will be bagged, and having to scan the whole bag makes sure that you will scan the entire body.
I remember when I was in Melbourne doing my fellowship, we had some of our children who were then scanned at the VIFM where you were, Chris, and it was that whole situation of actually the whole bag came back, even though they were a tiny little child, which was a surprising thing and a bit different from normal clinical work.
It's all about evidentiary. So what's in the bag is what comes to us to be examined. And we basically scan the bag without opening it so that we have a permanent digital record of what has come to us. That goes into our database as stored data. And so, especially in DVI, where you may have severely fragmented remains, you don't know what in that bag, what's bones, what's debris, what's animals, what's other things. And so what you need to do is document everything that's in the bag first. And then, if necessary, you can open the bag and remove things and so forth. But that, at least at the start, we always have this first digital record that is available for so-called digital exhumation. So should an issue come up in the future about maybe something that was missing or whatever, you can always go back to that original scan and survey that and then say, well, it was there or it wasn't there, so that we're confident with what we're looking at.
So I've got two technical questions for you, actually, Chris. I think probably one is very easy and one might be a bit more technical. The first is the blue metal imaging that you're using. Why do you use that?
Blue metal is just a really good way. I mean, it doesn't have to be blue. It can be any other color. Siemens tends to do it in red. It's just the first scanner I had a Toshiba, which we had Vitria, and Vitria just came out blue. And so it just is with blue metal. It's sort of a nice word. So I create the templates myself. So I've created blue for all our ongoing scanners. We use Singovia as our workstation. So I've just put in my own little program and blue metal. And basically it's just a 3D map of anything with a very high Hounsfield unit density. It's not specific for metal, obviously, because it's all on Hounsfield units. So the enamel of teeth will show up, and the dentist bone in the body, which is the otic capsule around the inner ear, also will show up often in blue metal. You know that because we can recognize it. And then anything else that's metallic tends to show up. And it's a really good way to survey the body in 3D. You can rotate it and whatever, find out where these things are located, and then you can go to the axial, coronal and sagittal recons to get a better view of what it actually is.
That's interesting. And the post-mortem CTA, how does that work? And sort of a part two question is, if you've got somebody who is brain dead because of cerebral edema in life, and they're not getting any contrast into their brain in a contrast CT scan when they're scanned clinically, how do you get contrast in their post-mortem?
So I'll answer two questions. First is CT angiography. Claire does it a bit differently in Leicester. We have a technique of whole body CT angiography. So we cannulate usually the femoral artery and the femoral vein, and we basically just fill the entire vascular system with contrast. So it's about 3 litres of contrast diluted in a 1 in 10 solution using a substance called polyethylene glycol, which is a bit like warm honey. So it makes it quite viscous and fills every artery and every vein pretty much. Surprisingly, after death, most blood does not clot. You do get some clotting, but most blood doesn't clot. So you can actually fill the entire vascular tree with contrast, and then you just do CT. So we use it as a whole body assessment. Now, sometimes that's overkill. If we want to do, for example, an intracranial angiogram, we might just cannulate individual arteries directly. So we had a bleeding tonsillar fossa after a surgical procedure yesterday. So we just cannulated the common carotid artery and did a selective angiogram. So we don't always do whole body, but that's our preferred technique because it's remote from where the pathology is so that we don't disturb the area of potential bleeding. So we're remote from that. We inject through the groins. The issue of raised intracranial pressure is a very interesting one. So we've done quite a lot of work in this, and you can't overcome intracranial pressure in death like you can't in life. So it's very difficult to get contrast into the cranial cavity in someone who's brain dead, who's got a grossly swollen brain. So what you have to do is remove the skull cap, for example. You can take off the skull, and that does relieve the pressure. And sometimes you're looking at skull base arteries, and by actually cannulating individual arteries, you can actually sometimes force contrast up intracranial that you wouldn't necessarily be able to do in life, but perhaps with a syringe and a fair amount of pressure, you can get contrast to go up, in particular to the basal arteries, and that's most importantly in the, as I presented in my talk, the basal subarachnoid hemorrhage story of the punch and the vertebral artery dissection. With reasonable pressure on the syringe, you can get it to at least go up into the vertebral arteries and show whether there's a contrast leak.
Claire, Chris alluded to the fact that you do it slightly different in Leicester.
We focus mainly on cardiac angiography. Okay. So we cannulate the carotid artery and use a Foley catheter into the ascending aorta, blow up the balloon to occlude the aorta, and then put contrast directly into the coronary arteries. And the reason for doing that is most of our work is done now to investigate natural deaths. And at the time we started doing this, ischemic heart disease was the most common cause of death that we needed to diagnose in the population that were being referred for imaging. And that's why we decided to target the cardiac work.
The coronaries. And so, I suppose I hadn't really appreciated that you didn't get blood clotting like early. What sort of window do you have to be able to do post-mortem CTA?
It doesn't clot. That's so it stays liquid. So you have plenty of time. In fact, even in decomposed body, you can do angiography. It's not as good, but you can certainly do it. It's not a timing issue. It's just some people clot some vessels more than others. The major problems, pulmonary arteries, I would say, and that's one of the main problems with postmortem CTA is that you can't really differentiate antemortem from postmortem clot in pulmonary arteries to look for pulmonary embolism. But most other arteries, the aorta and the heart and so forth, there's usually not that much clot. The blood remains liquid. It forms a hematocrit, so you get the sort of pooling of red cells posteriorly and the supernatant, and it just sort of mixes up once you inject contrast. And you can do beautiful whole body angiograms, just like a clinical case, except you're not getting the arterial phase, whatever phase, because obviously you're just filling the tubes. So it's just a matter of filling the tubes that you want to fill, and then you scan.
That's fascinating. We're going to wrap up here, I think, but before we do, what I'd like to do is perhaps talk about resilience. I'd mentioned in my talk that people ask me, why on earth would I do expert witness work if I have to look at bodies of children who have been abused? And my answer to the question was, well, I can't change what's happened, but maybe I can help bring the person who did it to justice, and also help that child be removed from the situation where they were injured, and maybe their siblings as well. So at least I get to think about some positive bits about future care for that child or their siblings. How have you managed to cope with some of the stuff that you've seen? And do you manage to leave it at work, or does it follow you home? Perhaps I come to you first, Claire.
Yeah, I think very much the same. It's all about looking to see what you can do to help the family and support them going forwards, and doing your best by being able to take care of their loved one for them as well, and knowing that you're doing the best for that person and their family and relatives. I don't think you can do this work without it bothering you, but I think it's important that it doesn't bother you to the point that it is going home with you all the time. Yes, there are always cases that I won't forget, but touch wood, it's never bothered me so much I didn't want to come back to work the next day. And I think that's the difference. And particularly when you're doing something like DVI, when it is absolutely overload, it's really important that you're working with a good team, because you can't go out and talk to the general public and to your family and things. So I think working with a really good team that you can sort of de-stress with at the end of the day, and even if it's just one case, again, at Leicester we have a team of radiographers and a team of staff, so having colleagues that you can go and talk to, I think, is really important.
How about you, Chris?
I think it's because I'm contributing to, medico-legal death investigation gets done whether I'm here or not. And I think I can really make a difference using radiology. I think I make a big difference every day. DVI is the same. I talk about the Black Saturday bushfires that we had here in Melbourne. Massive problem, 174 deaths. And it was the most overwhelming experience. So it was the worst thing I've ever done in my medical career, but it was the best thing I've ever done in my medical career. I was completely overwhelmed emotionally and whatever, but I felt that I was doing incredible things to try and help families find their loved ones that were missing. So it's that sort of thing. I think you're making a contribution. In terms of the stress and stuff, I think everyday work doesn't really affect me so much. I think children probably are the things that do affect me the most, I would say, seeing young children with trauma. And what I agree with Claire, it's the team. After the DVI, every night after the DVI, we'd all go to the pub and sit and have a drink and just talk amongst ourselves, because that's all we could talk to. But just debriefing, just getting out of your system, I think. And fortunately, like Claire, I've been doing it for a long time now. It doesn't seem to have affected me. Maybe I should ask my wife about that. But no, it's a feeling that I make a contribution. And to be fair, I actually think sometimes in my death investigations I make more contribution than the living. So, justice, making sure that the right things are done, that there's not injustice as well, that people don't get convicted incorrectly or the other way around. That's where I get something out of it. Yeah.
Fantastic. Well, thank you both for joining me today for this panel. Thank you for your talks for Radiopedia, and I hope we see you again soon.
Thanks, Jeremy.
Thank you.
Thank you to Jeremy, Chris, and Claire for that really fascinating discussion there. And before you say it, Gaylord, I'm going to steal one of your classic lines here. I'm just glad we have people like Jeremy, Chris, and Claire who deal with important areas like this.
Very much. And the subtext of that line is always, because I'm glad I don't have to do it.
Absolutely.
But yeah, I'm glad. And the question Jeremy posed at the end about whether Chris or Claire took their work home with them, whether it affected them. It's something I don't think, we've discussed it here on the podcast before when we spoke to Nathan Manning, the interventional radiologist, but I'm not sure that as a profession we discuss that enough. Our job is deeply abnormal compared to normal human experience. We see things every day. And in the case of radiologists, not directly necessarily, but we see new diagnosis of cancer or death or, strokes, etc., multiple times every day. And you just become sort of endured to it. It remains really weird that that's the case. And I was thinking about this just yesterday. I gave a tute to some of my trainees in the morning. I have to admit that I went in there a little bit punchy and grouchy. I haven't been around the department as much as I usually am, so I don't know these guys as much. And it's like, you're only 170 days away from your exam. And as I say to my two kids, just do better. But I was speaking to my fellow David afterwards, and he said, if it takes a bit of fear of your tutes for them to study harder, that's probably a good thing. Yeah, that's probably true. But shouldn't your fear of being a mediocre radiologist and miss cancer and misdiagnose patients and have permanent effects on their life be motivation enough to study really hard? And I think that's like proof that you become used to this weird thing that you're doing. That being in a tutorial with Frank being grouchy may be more motivating than the thing you do.
Even if you didn't become used to it, I think ego and embarrassment is such a strong motivator in
true.
what we do. And I'd like to say empathy and altruism is a very strong driver, but I don't think in a lot of people, I don't think it is. And the more I get on in years in radiology, the more, unfortunately, I see less and less of that empathy.
Well, I think partly that's because we're more and more remote from the patient that's on the other end of the scanner.
If the patient's in front of you, it's easier to be more empathic. Yeah. But no, I agree. The motivation for those, particularly those hot seat type practice sessions, is very much, I don't want to embarrass myself in front of not only Frank, but my other trainees. And so that's what really drives them. But in the back of your mind, hopefully you're thinking they're doing this because they want to be a really good radiologist and help patients.
The stakes are high, right? Like you forget it because you do it 50 times or 100 times a day. But every scan that comes up, the stakes are potentially literally life and death. And that is a bizarre thing to do as your daily job. Anyway.
I think there's a stealth goat in this somewhere, Gayla. There's something here. It's not as strong as some of your goats, but there's something.
This is we've had a necro-radiologist and a stealth goat.
Now, is there anything else to chat about from this panel discussion?
Right. Yep. Sorry. I think this fortnightly podcast thing means I'm in goat withdrawal.
So you have to throw it in.
A few in. No, there were a couple of things that I really struck me and I wanted to bring up. The first thing that was only sort of touched on was the idea of cerebral swelling post-mortem.
Oh, they did mention a brain at some point.
They did.
You'd latch onto that.
I suddenly focused. It's like my cocktail reflex. But there's this idea that this misunderstanding of cytotoxic edema that is throughout pretty much everyone who talks about it, everyone who teaches it, everything you read about it, talks about cytotoxic edema being a cause of brain swelling.
Mm-hmm.
And it's not. And that's why if you suddenly die of a cardiac arrest, post-mortem imaging won't show a lot of cerebral swelling. It'll show cytotoxic edema, meaning fluid.
Intracellular fluid.
Well, yeah, fluid from the extracellular compartment will move into cells and you'll get cellular swelling. But because there's just that much fluid, there's no extra mass. To get mass effect, you need to have circulation bringing in more water. And so really with cytotoxic edema leads to this thing that people don't talk about called osmotic edema, which is where you pull in additional fluid from capillaries to replenish the extracellular space. And that's what gives you cerebral swelling.
And this is why a DWI MR will show you cytotoxic edema instantly because it's telling you about how much restricted diffusion when all the water's sitting inside the cell membranes rather than in the extracellular space. Whereas your CT will take hours before you've got that low density because that's really osmotic edema.
Yeah, or your flare or your T2. Yeah. And so you really need that perfusion, that cardiac circulation to allow swelling. And in fact, why non-reperfused infarcts don't swell as much as those that where the clot breaks down or where you have clot retrieval, but an infarct anyway. They swell a lot more. Anyway, that was something that only caught my attention because I remember being surprised at thinking, oh, yeah, brains, why do these post-mortem MRIs not look like people who have had a terrible hypoxic ischemic brain injury? And that's the reason. But the other one was something I'd never known before, and that was the comment Chris made about blood not clotting, which I found surprising. So I did a little bit of reading.
Oh, good one.
Which I've brought to class. And I found an article titled Biochemistry Changes That Occur After Death, Potential Markers for Determining Post-Mortem Interval by Donaldson and Lamont from 2013. And I think I'd like Donaldson and Lamont because the first sentence of this study is death is likely to result in very extensive biochemical changes in all body tissues.
Yep.
We're not certain. We think it's likely. Anyway, it goes on to say that in a corpse, the plasma pH decrease is significant and is thought to activate fibrinolysin enzymes, which prevent blood clotting, resulting in an increase in fluidity of blood. It suggests there are two causes for this drop in pH in a corpse that don't occur in a test tube of blood where you're used to seeing blood clot, or in a kidney dish during surgery or something. And it says, firstly, blood in a tube has no glucose store to supply fuel for anaerobic metabolism, and consequently, no significant lactate accumulation occurs to help lower the pH. And secondly, erythrocytes do not contain lysosomes, so autolysis does not occur, meaning acidic cellular metabolites such as carbon dioxide, hydrogen ions, formic acid, lactic acid that generate inside cells are not released rapidly from lysing cells to significantly lower pH, as would occur in a corpse. So there you go.
Yeah, it was interesting that they can still perform, other than maybe in the pulmonary arteries where sometimes they do get that post-mortem clot, that they can still perform angiograms. It's amazing. You just assume that stuff would stop moving and then clot off. I always thought that maybe it had something to do with the air. Exposure to the air would also cause the blood to clot, but maybe that's just a myth.
Well, no, that's true, because air embolism causes microemboli. That's not just bubbles, I don't think.
I would love to do some kind of observership or something at the Forensic Institute just to see some of this stuff. It would be fascinating, I think. Anything else to chat about?
I think that's probably okay. I think we should wrap it up.
So how can people get in contact with us, Frank?
Well, we're at Radiopedia on Twitter and Instagram, as well as at Frank Gayland and at Dr. Andrew Dixon. And you can, of course, email us at a podcast@radiopedia.org with any ideas and or feedback.
Yep. So should we have different names for the podcast in different parts of the world? Do you call your reporting room a reporting room or a reading room, or what else do you call it? Let us know. Do you like Frank's little "just do better" motto?
It's positive parenting.
Should that be the podcast motto? Let us know. Write into us. And if you want to help support Radiopedia, then you can become a paid supporter via the website or purchase an all-access pass to our online courses and our annual virtual conference. In doing so, you'll be helping us to give free conference access to people in 125 low and middle-income countries. I've been sorting something out related to this week, Gaylard. We had a very, very high bandwidth use for our conference streams because we have free access in all these low and middle income countries and a potential very high bill to pay. So we're working on that.
That's what happens when 6,000 or 7,000 people attend a conference.
I won't say which video provider we're in conversations with, but we're working our way through it, and we're hoping to maintain our viability into the future.
Well, how about this? If said video provider does give us a significant discount, we may mention them next podcast.
Yep. Frank will give his very best YouTube reactions to it. Oh my God, this is the best video provider. And what else can people do to help us out, Frank?
And of course, you can also help us out by leaving a 5-star review in the podcast app of your choosing.
Absolutely. All right. We'll catch you all again sometime soon in the reading room.
Or in the library with the wrench. Stay rad, everyone.
Stay rad. Yeah, look out for those cudgels, Gaylard.
And stealth goats.
Stealth goats. All right, see you in a couple of weeks, and maybe we'll talk about Oppenheimer.
Yeah, that'd be good.
Bye.
Bye-bye.